Acute care in the home is our episode topic. My guest is Dr. Andi Foley, an emergency services clinical nurse specialist in Western Idaho and the 2026 chairperson of the Academy of Emergency Nursing. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Well, Andi, thank you so much for joining us today.
Thanks for having me, Nick.
Before we get into our episode topic, can you share a little bit about yourself with our listeners?
I am an emergency services clinical nurse specialist in Western Idaho, and I'm also a clinical consultant for Mednition, which is a company that improves ED triage accuracy using AI software. I've been interested in ED triage most of my career. I was the section editor in the Journal of Emergency Nursing for the triage decisions section for over 10 years. And that experience led me to get into other publishing opportunities. Sheehy's Emergency Nursing Principles in Practice. I was the lead editor for the 8th edition of Sheehy's Manual of Emergency Care and for the forthcoming Emergency Nursing Core Curriculum 8th edition. And in addition to my interest in triage and in publishing, I'm also really interested in scope of practice and role responsibilities, and that interest got me involved in supporting practice and scope for medical imaging and radiologic care teams, as well as teams who are performing acute care in the home.
And so our topic today, it's a great transition, is acute care in the home. So what exactly are we talking about when we use those words, acute care in the home?
Acute care in the home, which I'm going to refer to as hospital at home, has actually been around since the 1970s. It started in France and it's worked its way around the globe. And it's not going to be a surprise to any of our listeners that in 2020, with the pandemic, we had to get a little bit more flexible about how we provided care. And the Centers for Medicare and Medicaid Services, CMS, used the historical experience of all of those programs to authorize the Acute Hospital Care at Home initiative. And that initiative has been renewed by CMS several times since initially in 2020. Participation in the program requires an application to receive a waiver. And when that waiver is approved, it allows hospitals to expand their inpatient prospective payment system for care delivery into the patient's home. As of July 2025, there were 400 hospitals across 142 systems in 39 different states providing hospital at home services, and 12 of those states also provide Medicaid coverage for hospital at home services. From an outcomes perspective, there's a growing body of published literature reporting that hospital at home has lower mortality rates, lower readmission, and general healthcare spending rates in the 30 days post-discharge. And again, no surprise to any of our listeners, patient experience statistics are pretty high for this group of patients.
Now, you mentioned earlier that you're a CNS that specializes in emergency care. So help me cross the bridge here on how you got involved in acute care in the home.
Absolutely. So I mentioned my interest and expertise in scope of practice discussions, and I'm in Western Idaho, where the scope for a paramedic is very generous. And the program that we were starting up was planning to use paramedics to provide care in the home. Since I work in emergency services and I also have some pre-hospital experience, I have a degree as an adult gerontology CNS. I was tasked with supporting the design of safe nursing and paramedic care for our program.
Tell us more about the requirements and outcome reporting for hospitals at home.
Most of the requirements are driven by the CMS waiver application. The waiver is specifically to remove that requirement in the Medicare conditions of participation for nursing services to be provided on site 24/7. So, with this waiver in mind and the requirement that the hospital shall ensure standard of care to treat an individual at home is the same as the standard of care to treat an individual as an inpatient of the hospital, hospitals have to figure out how to provide that same level of service. CMS does give some guardrails. So the patient has to be admitted by a hospital-based physician evaluation. That can be inpatient, it can be through the emergency department, but that does mean that there can't be admissions from an outpatient clinic or directly from a skilled or an assisted level nursing facility. There has to be 2 visits by clinicians, and this can be a physician, a nurse, and an advanced practice provider every day. One of those visits has to be from a physician, but that physician can be virtual or in person.
Now, you said physician real quick. What about an APP? What about a nurse practitioner or a physician assistant?
Great point. The requirements is that a physician has to meet with the patient virtually or in person every day, but that second visit could be an APP.
Okay.
Another requirement is that you've got to be able to do all of the clinical and ancillary services that the person needs during their stay. Durable medical equipment, lab services, pharmacy, radiology, all of those things have to be available in some way for that patient, not necessarily in the home, but they have to be available. And so the hospitals have to figure out, again, how that's going to happen. There has to be an availability for the patients and the caregivers to contact clinicians with questions or concerns 24/7. What that looks like is going to vary from program to program. It might be a phone number that the patient calls. It might be a help button that the patient presses or some version of leveraging technology. All the programs are a little bit different in that way. And last but not least, if the patient has an in-home emergency, somebody's got to be able to get there within 30 minutes. And so for our very, very rural areas that might be working with volunteer EMS, that's going to be a challenge in meeting that particular requirement of CMS. And then in terms of required reportables, there are only 2. If there's unanticipated mortality of the hospital at home patient, and you also have to report the number of patients who go into the hospital at home program and then need to be escalated back to what's called brick and mortar, so back to the traditional hospital setting.
What type of services and care is out of scope? What's not provided in a hospital at home program?
Pretty much anything that needs one-to-one nursing care, those folks would not be a good candidate. But beyond that, it's really based on the resources that's available to that hospital or that system. So many programs don't accept continuous monitoring like cardiac telemetry or continuous pulse oximetry. But some programs do have that infrastructure. So some programs are able to do that. Most programs only admit adult patients, but there are some pediatric programs across the United States. And oddly enough, patients who meet the standard for observation level care aren't included in the reimbursement through CMS, so many programs don't include that patient population. But again, some programs do, and then they figure out the cost and the reimbursement on the backside of their program.
So this leaves a lot of services and care that can be provided safely in the home. Like, how's this work? How do you do it?
Hospitals and systems have to figure it out. You've got to figure out the type of patient, and it might be through DRGs, it might be through various other means. What sorts of patients are you going to accept for care into the home? But let me do a An overview of what an admission and care looks like. Again, this is the program that I'm familiar with, so it's not a standard for all programs, but they should be fairly similar. So first and foremost, the physician or the APP evaluates the patient either in the inpatient setting or in the emergency department and determines that they're a good candidate for hospital at home from a clinical care perspective. Then we've got to figure out all of the rest of the psychosocial aspects. And so there's additional screening about the home. How many steps do you have to go up? Do you have a safe pathway to the bathroom? Do you have a way to keep food cold? And it doesn't necessarily have to be the person's home. It could be a friend's house that they allow you to stay at. I even heard about one program where a patient lived in an RV and a friend allowed him to park the RV in the friend's driveway so he could get care in his RV home that allowed, but he had a standard, a safe physical address location during his hospital at home admission. So once you do that additional screening, and the patient is determined to be a candidate, you start coordinating the handoff from either the inpatient or the ED team to the hospital at home team. Start coordinating that transport back to the patient's home. It might be via a skilled care transport service, and some programs actually allow the patient to drive themselves or a caregiver to drive them back home. Again, that's a decision that each program gets to make about how transport can happen if the patient is stable enough. Lots of coordination for logistics. If they're leveraging the use of technology like most programs do, there's some sort of home tech kit that needs to be delivered fairly quickly to the home. Various supplies, PPE for the clinicians, and whatever other supplies that program determines might be needed, IV start kits, those sorts of things. Pharmacy is in the background preparing medications. We're scheduling that paramedic or nurse first visit, other services that might need to be provided, such as PT or OT, social work. Sometimes that can be in person, sometimes that can be virtual, other virtual consultations with medical specialties. Nutrition services is preparing meals sometimes if needed. And then you have your first visit where you take the patient and their family through that tech kit. You ensure that the medications that they typically take on a day-to-day basis are sequestered somewhere so that we're only using the medications that are provided by the hospital, by the system, and making sure that patient and caregiver are comfortable with contacting virtual care 24/7. And so whatever that platform is, again, is it a button? Is it an iPad system is what is used a lot. Those home care visits can occur anytime from early morning to late evening. Some programs are available for an in-home visit 24/7, depends on their structure. And the program that I helped to implement, they decided they didn't want to go overnight, wanted to try and let that patient get their typical sleep, but also wanted to accommodate. Do we have an early bird patient? Maybe we could go out at 5 a.m. for them. Do we have a night owl? We could go out at 9 p.m. for those patients. And then in between, for someone who needs in-person help urgently, at those times, local EMS is called. In our system, that prompts a discharge from acute care in the home, and they would go to the emergency department. Depending on what's going on, if it's during an hour where we have an in-person APP available for the home, they might go to the home and be able to coordinate transport back to brick and mortar and not go back through the emergency department. So we want it to mirror processes in the inpatient setting as much as possible. When we started talking about the program to our inpatient teams, we would say it's like transferring a patient to the third floor. We're going to treat it exactly like that, exactly like an in-house transfer in our EHR, exactly like an in-house transfer if they have to come back to brick and mortar, with the exception that if they need 911, if a patient's admitted for, say, sepsis, and they start having stroke symptoms, that patient is most likely going to be discharged from hospital at home in our system and go through our emergency department for the stroke follow-up.
So how's that work from a revenue standpoint? Because you're essentially moving from a higher level of care, technically, from an acute care at home to a lower level of care by going back into an emergency department. It's physically you're moving from home to the ED, but theoretically you're going through the exit of a one-way door from an inpatient setting back into an ED.
That's a great question, and I don't exactly know the answer to that on the revenue side, other than to say it is a discharge from the hospital, so it would be a second admit for a new condition through the emergency department. CMS is the driver for this, but you've got to have operational folks who are also talking to your local payers and having those discussions with insurance companies so you can get contracts to expand your program as those payers make that available for you.
So what type of patients are we talking about? We're talking about like a 35-year-old that's got cellulitis that needs IV antibiotics, but that's the only reason why they're being admitted, that they need IV antibiotics. So they're going to go home and someone's going to come to them and give them IV antibiotics, and then they're going to be fine in a couple of days. Or are we talking about more elderly patients that have fallen and they're septic, and like where's the gamut run here on level of care appropriate patients for this type of service?
All of the above. For the program that I helped implement, it is medical surgical patients primarily, all ages, lots of different diagnostic indicators, all the way through that recovering elderly septic patient that you mentioned. And we're talking about expanding the program to post-op patients. So maybe they spend a day or half a day inpatient post-op, and for certain indications, maybe we can get them home. We're talking about the potential to expand our maternity program. So you deliver and spend a certain amount of time in the hospital, and perhaps you need just a little bit extra to go home with, and you get to go home with your new child. Really depends on the resources that your system has available. But again, primarily what my experience has been, what I've read in the literature, is medical surgical level patients.
Okay. Based on your experiences helping to implement a program for acute care in the home, what have you learned?
We definitely want to have backup plans for your backup plans, because things will go sideways. A paramedic isn't available, or a lab has too many visits and they can't come draw it, or physical therapy group that you partner with is busy for the day. And so you want to have those backup plans available. I told you I'm in Idaho. We have some very rural areas that are still within a 30-minute EMS catchment area. So you need to be thinking about things like, is there mobile cell service? What are the Wi-Fi capabilities? And then in any technologically based process, you've got to be thinking about downtime. So for us, we had to build additional in our EHR, and that meant building extra forms for downtime so that the teams would have the things that they were used to if they had to go to paper. The biggest learning for us, I think, was training plans. There were some really valid, rational reasons that we did not train as a full team, and that made sense at the time, but it resulted in this group figuring out an easier way to do something, which meant that this other group had additional work to accommodate and to standardize. And so training as a group may have helped to standardize across the entire platform. But I think the biggest thing that I learned is that you've got to be prepared for rapid change, especially initially to accommodate the unknown. Because even though our system partnered with a logistics vendor, like a third party partnership, who had lots of experience in hospital at home implementations. We learned things about our community and about our resources that we had to check and adjust in the moment to accommodate and to standardize. But in the end, patient satisfaction has been amazing. Our readmits are low. We have very few patients going back to brick and mortar. So all of the outcomes that the published literature suggests, we're also seeing in our program.
Acute care in the home has been our episode topic. Andi Foley, thank you so much for your time.
Thanks, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.